I have the pleasure of introducing our first speaker today, Dr. Eileen Sheesh. Dr. Sheesh is the medical director for the heart transplant program at main campus. She's a staff physician in the section of heart failure and transplantation cardiology in the Tomsig Department of Cardiovascular Medicine, Miller Family Heart, Vascular, and Thoracic Institute. She will be talking about heart failure stats, changing the face of heart failure.
Thank you so much, and what a pleasure. And to kick this summit off is pretty cool. So I'm going to begin with the statistics that we all want to know. And I have 4 objectives. I want you to walk away knowing the incidence and prevalence of heart failure. I want you to be able to identify heart failure risk factors, know the trends in heart failure hospitalization, and understand the mortality rates as well as the causes. And the data that we're going to be reviewing actually all comes from one publication, okay, that a lot of the people that are going to be speaking today are authors. And it is an annual report that kind of reviews the latest statistics. And actually, this was last published in 2024, first published in 2023, begun by Beacom Boskert, and it is published in the Journal of Cardiac Failure, and that's where you can find it. Okay, so we're going to begin with actually global data. Worldwide, there is an estimate of 55.5 million people living with heart failure. This is based on data from 2021 from 204 countries and territories. This is our best statistics, okay? And very fascinating. So what you see is kind of what you already know, that actually both women and men actually increase the prevalence of heart failure at older ages, peaking around 70 to 74, okay? And then it declines again. And I think you also have seen that there's different causes based on age, right? So if you had a younger patient, you'll see that the red, younger's on the far left, the figure's on the far right, but the younger is on the far left. And you'll see that actually the red is congenital heart disease. That is the most common, as well as actually a non-ischemic cardiomyopathy, which is displayed in green. On the far right is older patients, and as you expect, myocardial infarctions or an ischemic cardiomyopathy in blue is more common, as well as hypertension, right? So comorbidities. In the United States, out of the 55.5 million people living with heart failure, 6.7 million live in the United States. There's slightly more men than women, but the incidence is really similar between the women and the men that are over the age of 54. Okay, so we're talking about age. Does the US reflect the global data? And the answer is yes. On the far left, you'll see the trends over time. And the red and the blue are actually the older age groups. Okay, so it is more prevalent, just like we saw in the global data. It is the same in the United States. When we get closer to actually 2020, what you see is actually a little concerning. There is a decline in the prevalence among the elderly. So actually the blue and the red start to do a deep dive, right? But what you see is a slight increase in the younger populations, and that even includes the 20 to 39-year-olds, okay? I know it looks small, but it actually is still important. When we look at racial and ethnic differences, this is a study based on the multi-ethnic study of atherosclerosis, you actually have a higher incidence and prevalence of heart failure among Black individuals compared to Hispanics, whites, and Asians. Okay, number 2 objective, risk factors. When we think about risk factors, we really want to actually take a healthy cohort. We want to follow them over time, and we want to actually figure out what factors cause the heart failure. That's what we want. And lo and behold, that study was recently published. They took 4 longitudinal community cohorts that you're familiar with, the Framingham Heart Study, the Prevention of Renal and vascular end-stage disease, the multi-ethnic study of atherosclerosis, and the cardiovascular health study. And they follow these healthy people for 12 and a half years. That's what you want. And they found sex differences. Some of this you're going to know, and some of this will be a surprise. So you know that men are more likely to have coronary disease, and lo and behold, myocardial infarction was a more common risk factor for men compared to women. With regards to women, actually, hypertension, you think of those, cute little old ladies admitted to the hospital with hypertension, and that's what you see. Diabetes, you may not have known, is a higher risk factor actually for heart failure in women compared to men. And then the two that I think are important are really for you to recognize that atrial fibrillation is a higher risk factor for women. So therefore, tachy-induced cardiomyopathy is more common, right? So you're going to have a need for those beta blockers. And then left bundle branch block is really fascinating because there's always been a better benefit in women with CRT. And I just want to kind of point out that the underlying cause may be left bundle branch block. The same group followed the patients actually for biomarkers while they were healthy and found which ones actually predicted heart failure. And not a surprise here. Natriuretic peptides actually predicted for both women and men, and actually regardless of your ejection fraction, right? HFrEF and HFpEF, not a surprise. Cardiac troponins actually require cell death. So of course it's going to predict HFrEF, right, with reduction in loss of cell muscle. So it is a better predictor for HFrEF than HFpEF. Okay, we're going to move on to number 3, hospitalizations. Our best databases get with the guidelines. It actually had, at the time of this study, 529 hospitals in the United States with almost 560,000 patients. And the prevalence of HFrEF and HFpEF are almost the same. They dominate the reason for being admitted, slightly more with HFrEF. And the mid-range is really actually with the EF 41 to 50 is a very small population. When we think about what happens over time, this is the data that actually shows that. This is a national inpatient sample, so hospitalizations, taking a small sample. The patients were from 2004 to 2018, and they were age adjusted. Okay, so now we're going to look at the first figure on the far left, which is sex, and males are hospitalized more frequently than women. It's more prevalent in males, they're hospitalized more. With regards to race and ethnicity, you'll see that the Black individuals are, again, disadvantaged. They have more hospitalizations. It's not disadvantaged to be hospitalized, but it's that the morbidity associated is a lot. And they have more than the white and Hispanics. With regards to heart failure hospitalizations, there are more hospitalizations in urban, actually, hospitals than rural. And there's also variation based on region. So if you live in the South, there's actually more patients who have both HFrEF and HFpEF that are hospitalized compared to the West Coast, where there is actually the least amount. When we talk about readmissions, and this is over a 5-year period of time, women are hospitalized or readmitted more often than men. So that is very interesting. And women are more likely to have HFpEF, so not surprising that actually HFpEF actually has a higher hospitalization rate than HFrEF. Okay, our final objective is mortality. And here actually is based on the CDC Wonder database, and the data goes up to 2023, and you can see that the mortality is higher among men compared to women, and that's the red. Should be the other color, right? I should probably have flipped it. It wasn't my figure, so came from our So the second is actually with regards to race and ethnicity, and Black individuals have a higher mortality than any other actually racial or ethnic group. And I think that's very important to remember. And that's the red. When we talk about age, this is on the far left, age-adjusted data. And here you'll see actually that there was a decline up until about 2012. It peaked during the COVID pandemic, and it's now back on a decline for actually mortality due to heart failure. But I think more concerning is the fact that I told you there was a slightly higher prevalence of heart failure among the young, and this population is dying at a faster rate than actually the elderly. So here you see that actually the young between 35 and 44 have a curve going upwards with higher, than actually the elderly that is on the far, far right. And then the last is actually causes. And I love this slide because I just think it's really visual. But this is actually using a contemporary cohort where they actually pulled the data for dapagliflozin from the DAPA heart failure and liver populations. These are multi-center studies. And what they found is that there are differences in mortality caused based on your ejection fraction. And on the far left is actually the lower ejection fractions, and the cause is more likely to be sudden death. That's the group we have the guidelines for ICDs, and heart failure death, right? So those are the causes. On the far right are those with HFpEF, and is more likely to actually be non-cardiovascular. So in summary, I want you just to remember that the global prevalence of heart failure is 55.5 million people. 6.7 are from the United States. Black individuals have a higher incidence, they have a higher prevalence, they have a higher hospitalization rate, as well as mortality compared to the other ethnic and racial groups. With regards to age, I think it's just important to remember that our young actually are starting to develop heart failure and that they have a very high mortality. So please recognize that when they're sick, they may not show all the signs, and we need to recognize the importance of it. There are more men than women with really heart failure, and this is seen in hospitalizations as well as mortality. And I want you to remember that there are sex differences in the underlying cause. And so that is that men are more likely to have MIs, women are more likely to have hypertension, diabetes, AFib, and left bundle branch block. And I think that pretty much ends my talk.
Thank you, Dr. Hish. Our next speaker is Dr. Jerry Estep. Dr. Estep received his medical degree from Baylor College of Medicine. He completed his residency at the University of Texas Southwestern, and his fellowship in cardiology and heart transplant and heart failure at the Houston Methodist Hospital and the Texas Heart Institute. Dr. Estep is currently the division chair of the cardiovascular medicine at the Cleveland Clinic, Florida. And he will be talking to us today about the next frontier, earlier diagnosis and treatment of heart failure.
So thank you for the kind introduction and the kind invite. Wonderful to see friends and colleagues, and great opportunity to tackle this topic, which is certainly a large one. I too have 4 objectives. I want to provide an overview of the current state of heart failure, recommendations to diagnose and treat this condition, leveraging our staging classification and criteria supported by the ACC and AHA. I want to define the importance of making an early diagnosis, review the intent of guideline-directed management as opposed to just medical aspects and therapy, and then put in the context of next frontiers as it relates to selected areas of opportunities and possibilities to improve detection and management from a population health perspective. And so Eileen nicely highlighted those at risk for heart failure, a lot of work being done to minimize incident heart failure. I think where there's a real opportunity from a population health perspective is stage B heart failure, those without signs or symptoms, but have either structural heart disease or elevated filling pressures or risk factors plus elevated natriuretic peptides. And I think this is important to be clear about the criteria because it guides the reference, especially getting into the AI world. So I've put forth the structural heart disease, the echo Doppler, and certainly there are BNP and troponin cutoffs. And what is fascinating is that really not a lot of work as one would expect in this space. Certainly our guidelines prompt us to consider ordering NT-proBNP as a 2A in patients at risk. What is exemplified on the right is the ERIC study, which is a prospective population examination to understand incident cardiovascular disease, including heart failure. What they nicely did is looked at reclassifications of patients that were stage A, leveraging biomarkers which were collected prospectively. This is the late 1980s. And you can see 1 in 5 patients were classified as stage B just by biomarker alone. This certainly predates the current recommendations and criteria. And when you look at the hazard ratio, not only for incident heart failure, HFrEF or HFpEF, but death is certainly the highest in those with echo and positive biomarker evidence of underlying structural disease that certainly merits more attention. Very nice publication by Dr. Chima and colleagues that highlight that AI is really positioned to revolutionize our field along the different stages, taking data inputs from wearables, waveforms like EKG, the electronic health record, and others to put forth improvement, not only in how we interact with patients at risk in stage A, but how we potentially can screen for asymptomatic LV dysfunction. So I'd like to present a few observations in this regard. This stems from the ERIC prospective population-based study, and they looked at 12-lead digital EKGs, and they were interested in understanding the analysis of ECG alone using AI to yield heart failure prediction compared to the Framing Heart Study Heart Failure Risk Calculator and the ERIC Heart Failure Risk Calculator. And what you can appreciate is an AUC of 0.82. The analysis using ECG AI alone yielded a prediction comparable to these more robust, if you will, risk calculators that take more into consideration. So very intriguing and very much like the publication from our colleagues from Mayo now 4 years past, where they did a prospective examination of AI-enabled algorithm to detect EF under 50%, significant effort, 129 specialty medical teams, over 180 clinicians in both the intervention using ECG and prompts to guide echo acquisition versus standard of care in over 22,000 patients. Eric Topol wrote the editorial, and you can appreciate the integration from a clinical pathway of the electronic health record notification to prompt acquisition of an echo to detect stage B. And they did indeed note a higher percentage in the interventional group versus standard of care that was statistically significant. So clinical pathway and integration is going to be key. In the most recent publication from our colleagues from Yale, leveraging AI applied to the EKG, multinational study, including not only the United States, but the UK and Brazil. And you can appreciate the large number of patients at risk, robust hazards across probabilities, greater iterations of the AI, the greater the hazard ratio, and a C statistic that range from 0.7 to 0.8. And when compared to standard, that is leveraging demographics, labs, QRS from the ECG using AI-generated learning, incremental in terms of identifying those with new onset heart failure. So robust data that's coming out, and there's a few publications from a meta-analysis perspective with an AUC to define the diagnostic accuracy of AI ECG to detect asymptomatic LV dysfunction up to 0.92. So certainly encouraging, a lot to continue to learn. And we know what I would qualify as historic data that acting on this patient population matters. And this is to remind those that don't remember the SOLVE prevention, use of ACE inhibitor in those with LV dysfunction asymptomatic, improvements in terms of death or heart failure hospitalization. And our guidelines certainly guide us in terms of treatment considerations in these asymptomatic patients as listed here. I'm going to transition to stage C heart failure. You know, setting the stage for the rest of the meeting is important. We can't lose sight of our guideline-directed medical therapy, right? Management and therapy are going to be key. And as highlighted by Eileen, hospitalizations are a major comorbidity and cost for this patient population. I very much like this publication from Dr. Wang and colleagues that highlighted the implication when the diagnosis is made as an inpatient, the red curve, versus an outpatient, and patients do worse. That is very much in line what we would we would think. And when one takes a step back and says, well, how are we defining this patient, leveraging the universal definition of stage heart failure patients, it's certainly with symptoms and signs and at least elevated natriuretic peptides or objective evidence of pulmonary or systemic congestion. And on the right is the breadth of trial that really has positioned the importance of natriuretic peptides and cutoffs. So the current state is quite simple in how we do this, right? It's the history, the physical exam in labs, natriuretic peptide followed by echo to then categorize heart failure. I think there's a real role to do better, leveraging AI, machine learning, deep learning. I look forward to hearing about the cardiomyopathy talk later in this session and remote monitoring talk. But I think it's important to leverage what we know now based on how we're detecting these patients. And our 4 pillars have really changed the landscape. And I was sitting and thinking, what is going to be the next pillar, right? And so I look forward to Dr. Randall Starling's talk. The bar is high because it's a reduction in all-cause mortality. So let's review some of the data. And I've mentioned the importance of GTMT with management and therapy, encompassing clinical evaluation, diagnostic testing, and pharmacologic and procedure device-based treatments. So the paradigm heart failure was landmark, leveraging neprilysin inhibition to create this enhancement in endogenous vasoactive peptides, and compared to ACE inhibitor, significant improvement in terms of cardiovascular death and heart failure hospitalization reduction is exemplified on the right, and improvement in death from any cause. That is the bar for in my mind, as a pillar. And when you look at the work done on leveraging this medication in the hospital, once they're off vasoactive agents, significant improvement, a surrogate for significant improvement in potentially morbidity and mortality, but change in NT-proBNP, more favorable on Entresto versus enalapril. Beta blockers have been cornerstone. I'm not going to go through all the details, but overall reductions in mortality. And this is landmark. And I always tell a patient and the fellows, it's a dose response efficacy relationship. Lars Svensson mentioned recovery as part of our vision and mission. And so we'd love to see improvement in ejection fraction, and we can achieve that in selected patients. And so dose matters. It's not only true for beta blockers, but it's true for ARNI, ACE, or ARB. And so we want to achieve the doses that were studied in the clinical trials. We don't want to lose sight of the MRAs. I'm not going to go through the details. From a population health perspective, in terms of implementation of strategies to monitor, we've got to be very cognizant of the side effects, but certainly MRA, spironolactone in New York Heart Class 3 patients, despite use of beta blockers and ACE inhibitors at the time, had a survival advantage. Transitioning to the SGLT2 inhibitors, very similar story in terms of meeting the primary outcome in those with HFrEF. As you can see on the right, significant improvement in less worsening heart failure or death. And again, the bar set, improvement in death with use of this medication. A lot to continue to learn in terms of how these medications work. It minimizes myocardial stiffness, minimizes inflammation, improves energetics. So it's certainly helping above and beyond how it's used to treat diabetes. And the Emperor reduced heart failure trial expanded it to those with EF that were further reduced, median around 27%. And very similar story with significant improvement in the primary outcome compared to placebo as defined here. And so we have these expert consensus decision pathways where we want to use these medications. And these are our standard for HFrEF and evolving for HFpEF. And there's going to be dedicated discussion on HFpEF. I won't go through all the details, but just to highlight that Emperor Preserved demonstrated significant improvement in the meaningful endpoint with use of empagliflozin versus placebo in those with heart failure with preserved ejection fraction. ARNI, based on pooled data, has been approved. The trial Paragon didn't meet its primary endpoint, but in a pre-specified group, benefit in those with lower EF and in women. And so it certainly has an indication based upon this pooled data and the FDA weighing in. And so the SGL2s for HFpEF, I think, are here to stay. It's a 2A, and for ARNI 2B, but it's nice to have these at our disposal. And where I think the future lies is earlier use, continued use, even in the context of worsening renal function, and really introduction by primary care specialists, in addition to cardiologists and those with cardiorenal metabolic syndrome. And so I think there's going to be a lot more to learn on leveraging SGLT2 in those with elevated biomarkers, perhaps where we don't have the documented structural reverse remodeling signs. Not going to spend a lot because there's very little about best practice titration. Strong heart failure, a multinational open label randomized trial, showed us that being more aggressive with using these medicines, all 4 in the hospital, and then at 2 weeks trying to get to goal dosages, these patients fared better. How that's going to play out at the population level, we're going to learn more about, leveraging what we learned from the Ontario experience and using MRA in patients as it relates to hyperkalemia and side effects. Not going to spend much time on the GLP receptor antagonists, the GLP-1s. Certainly in diabetes and obesity, hints of efficacy based on randomized control trials, but I call it out in that those with HFrEF or even more advanced heart failure in terms of mechanisms of potential increase of risk, a lot more information needs to be put forth for us to put this as a potential next pillar. So I think we're far from that as it stands now. We had a publication, a group of us that put forth a summary on device-based therapies. I encourage you to look at this. And certainly in this session, you're going to hear about cardiac contractility modulation, baroreflex activation therapy, and selected patients can improve functional capacity and quality of life. So there is a gap in these stage C patients after you're optimizing medicines where they may benefit from devices. And as heart failure specialists, we certainly take into consideration all the potential devices as listed here and weigh projected benefits and risks. And I think AI is going to help along these lines, in particular, those with residual risk and that have advanced heart failure. So I'm going to end by showing a couple of slides about where I think the field's headed. Certainly AI will play a role. We know our staging systems are not perfect. Classifications can be difficult. And in the end, in many ways, it's subjective. And so when you look at CardioMEMS in the 5 data sets, 2 of which were randomized control trials, we're learning a lot about the implication of a baseline mean pulmonary pressure. You appreciate what is looking like a linear relationship with probability of death. This holds true across the ejection fraction. Here's listed the probability of death, in particular for HFrEF, approaching 25% when just above 30 millimeters of mercury. And so this is a topic of investigation as a new frontier. Mike Tong and myself have the privilege to be national PIs in this effort. And part of this is to define objective disease state criteria to trigger advanced heart failure referral and advanced heart failure end organ interventions. And so front and center in this is the mean pulmonary pressure. And after optimizing medicine, if it's persistent above 30, we think that's a major red flag that's objective. Monitoring these patients, considering randomization of these patients based on HeartMate 3 versus medical management. But for those under 30, we're going to learn a lot about in the single arm registry. So it's a fascinating trial. Look forward to recruitment. This is my last slide, Future Horizons. It's an exciting space. We're going to hear a lot about medical potentials, but renal artery pressure optimizers, invasive hemodynamics, cath-based LV reconstruction, that's device reverse remodeling, renal venous pressure modifiers, and interatrial shunts. So the take-home messages, I know I've covered a lot in broad strokes. A timely and accurate heart failure diagnosis is the gateway to effective treatment and can indeed prevent progression, change the trajectory, and improve, most importantly, survival and quality of life for patients. GTMT is key, but recognize it tells a lot about evaluation, diagnostics, and don't forget about device-based interventions. And I think AI has a real potential to revolutionize our field. Very much look forward to the discussion. And again, appreciate the opportunity to share some of my thoughts today. Thank you.
Thank you, Dr. Estep. We now welcome Dr. Trey Martin. Dr. Martin serves as the Director of Heart Failure Population Health and as a staff cardiologist in the section of heart failure and cardiac transplantation at Cleveland Clinic main campus. He will be discussing harnessing tech for GDMT optimization and readmission reduction.
Thanks everybody for being here. So my objectives for today are to talk about how we can leverage mostly focusing on the electronic health record and tracking health system performance around GDMT, how we can used EHR-based or EHR-triggered interventions for improving GDMT optimization, talk about how we've used our EHR infrastructure to implement a care model around acute heart failure. And then lastly, the next frontier of what I believe to be EHR tools around AI automation of chart review. So starting with the EHR, and as the primer that Dr. Estep just gave, despite the growing evidence of benefit for quadruple therapy in HFrEF, and even in mildly reduced EF, there's poor implementation of GDMT both nationally and internationally. And so in that vein, in order to measure comprehensive therapy for GDMT, we developed a Cleveland Clinic GDMT score, which mirrors other scores that are in publication. But essentially, you get credit or reward for adding different agents of comprehensive therapy, with an optimal score being 8. We then took this score and, importantly, we validated it in our own internal data. So across 6,000 HFrEF patients across our system, this score, a higher score was associated with improved survival, and a lower score was associated with death and hospitalization. And we also have the ability for clinicians to view this curated data for their own patients and for the health system. So when I say a curated EHR-based registry, what I mean is that variables of interest to us as heart failure specialists when looking at our patient populations, so things like heart failure admissions, NT-proBNP, EGFR, medical therapy for heart failure, et cetera, we have the ability to kind of get a glance at in real time. And this is built across over 300 clinics and 23 hospitals across 2 states. And we have over 50,000 patients who are contained in this updating registry. And if we think about in terms of numbers, we have around 25,000 patients who have had an echo with us in the last 24 months. And just to point out that we can actually then use this data, this is unpublished but presented at ACC, where the GDMT score actually was prognostic in HFpEF as well as mildly reduced ejection fraction. So intriguing that, on the back of STRONG, this data also indicates that there may be an association with better comprehensive therapy across the EF spectrum. And so we also were able to look at internally what is driving the use of good comprehensive therapy. And what we found, a little bit surprisingly, was that who you saw was the biggest determinant of having good medical therapy. So if you saw a heart failure specialist in the last 12 months, you were much more likely to have good medical therapy. Similarly, if you were hospitalized, you're much more likely to have lower medical therapy. And it was not things so much as your renal function or your blood pressure or other physiologic things that limited GDMT in the end. And so, unfortunately, we don't have the availability or bandwidth for a heart failure specialist to see every heart failure patient. So this has really taken a collaborative effort over the last couple of years involving general cardiologists and particularly pharmacists and our nurse practitioner teams, not just in cardiology, but in primary care as well. And as Jerry, alluded to, focusing on SGLT2 inhibitors in particular because of multi-disease indications and familiarity of primary care in prescribing that agent, we've really been able to radically improve our prescribing rates, both in HFpEF and REF, but still more work to go over the last couple of years. But I would also point out our ability to track is something that, I think is very important, and also, look at regions or practices that are over or underperforming. So moving on to EHR-based interventions for GDMT optimization. What I would like to point out is this study, which is called Prompt Acute Heart Failure. And the population was those who had acute heart failure, were getting IV diuretics in the hospital, and had a suboptimal GDMT score. And they had a tailored GDMT best practice alert. And the take-home point here is that there was no difference between the alert and no alert in terms of prescribing of medicines. And so when you take busy clinicians and give them a best practice alert, many of you who are clinically active may not be surprised that it didn't actually move the needle very much. And in this slide, I attempt to summarize 7 years approximately of EHR-based clinical trials and evidence But my personal takeaways from this data is that clinician and patient EHR alerting alone, although potentially lower cost and scalable, has modest or no impact. Whereas EHR activation of dedicated teams is very effective, does involve dedicated resources, and has variable cost. And I think there's a lot of data and nuance to a lot of these things, but I think those are the big takeaways in terms of strategies of care. And so just to give you an example of something that's to come and we need more data around is EHR integration of remote patient monitoring. And this is from a company called Story Health, but they had, they have this interface here where you can see device parameters, including cardiomems in the top line, daily blood pressures, heart rates, weights, coming in via Bluetooth. And then you can also see the alignment with initiation of therapies. And so I think it's that part of that serial data coming in that allows more comfort in optimizing GDMT more quickly, because a lot of us are uncomfortable with making a spot decision on one clinic blood pressure, right? So the data can be very useful, but the challenges remain with how do we integrate these technologies into our EHR and how do we staff them? And that's a whole separate discussion. There will be data coming out on this platform compared to usual care, hopefully later this year. A trial that we were the highest enroller for is now, is fully enrolled. And so hopefully we'll get, an answer to whether this is an effective tool in the coming months. So moving on to care model implementation in acute heart failure. So you've already heard about the STRONG-HF trial from Dr. Estep. Again, rapid titration of GDMT in the acute heart failure setting across the EF spectrum, importantly with elevated natriuretic peptides. So median NT-proBNP in this trial was 3,000 and randomized to aggressive inpatient titration and post-discharge continued titration. The trial was stopped early for clear benefit in the aggressive titration arm using ACE-ARB, ARNI, beta blocker, and MRA. Again, bucking some of the conventional wisdom around EF categories and where these medicines are beneficial, but a lot more work is needed in that regard. And so taking those lessons, we have tried to do something along those lines in recreating how we developed this model in a US system of care. STRONG-HF was mostly run out of Europe. So we have developed standardized criteria around defining acute heart failure. And that involves heart failure diagnosis ICD codes, the administration of IV diuretics, and not being on dialysis, importantly. And through this process, through our EHR, we've developed real-time tracking methods across 23 hospitals. And so at any given time, we know how many patients meet this criteria at all of our centers. And this was just a snapshot I took from a couple of days ago, but at any given time, there's 142 patients. There were 142 patients who met this criteria on our Cleveland campus and 16 in Indian River in Florida. We also, I should highlight, created a subgroup called advanced heart failure, where if you had a low EF plus 2 admissions in the prior 12 months, you would get a separate follow-up cadence with a heart failure specialist. And so this is about standardizing identification of patients, as well as standardizing the automated follow-up that we arrange for you after the hospital with both our heart failure APPs, as well as general cardiology or advanced heart failure, depending on your risk profile. And so this is what it looks like when you're a discharging hospitalist currently in Florida, in close collaboration with Jerry Estep and his team, is you have a 2-component follow-up order when you meet our identification criteria. And once that is signed, that goes over to our scheduling team, who knows whether you're advanced or just regular acute heart failure. And there's a different cadence of visits that's set up. And so, using this model so far, we've seen a 4x increase in the number of patients who are appropriately seeing cardiology within 30 days of discharge. So very exciting about this. And I think it's important that we're also not just, handshaking with these patients, but really pushing GDMT during those visits. I want to point out another aspect of implementation within the hospital, adapting the Implement HF study, which was run by a friend of mine on Keep Bot out of the MGB system in Boston. looking at pharmacist-led and heart failure cardiologist collaborative consultation of GDMT, mostly for hospitalists. And so what they did was they did a daily EHR screening, they developed preliminary recommendations, agreed upon them, and then either placed a note or paged the team to encourage them to use those medications. And it improved what they found in virtual consult compared to usual care. They met their primary endpoint in terms of GDMT score improvement. And the particular benefit was in MRA and beta blocker and not in some of our newer agents. We have taken a similar approach at Cleveland Clinic, and we have partly to make this more scalable and used more long-term, we have not involved the cardiologist as prominently as the studied model. But we have used a long-term experienced heart failure pharmacist, Brad Williams, to do this both at our Fairview campus and our Cleveland campus, and have found that 77% of the recommendations he has been giving out have been accepted by the rounding hospitalists, which is great. They've been really appreciative of the price checks around SGLT2 inhibitors and ARNI in particular. And we've also found an increased use of our internal pharmacies, like our adherence and our home delivery pharmacies as well. And just to show you that some of the post-discharge clinics that are in Florida are using our GDMT score template. And this kind of makes you verify the reasons why you're titrating or not titrating certain medications, or whether you've hit target dose or there's a certain intolerance reason that you're not. So moving lastly to AI automation and chart review, the next frontier, hopefully. And so this, I think a lot of what we have used historically to track population health is what I would call structured data. So those are things that come out of labs, ejection fraction, ICD codes, things that we can readily extract if you're fortunate to work in a system like ours, and can get a reasonable sense of how certain patients are doing. What AI chart review and unstructured data gives us the opportunity to do is to actually look into the note text of imaging reports and progress notes, et cetera. And we've had the good fortune of partnering with a AI automated chart review vendor called Diania Health, which has a AI model that combines both structured data and unstructured data into drawing medical conclusions. And I will show you an example of this. And I think the power of it is very interesting. And so we use this tool as the first use case was around clinical trial identification. And so this is a concrete example. So this was for an amyloidosis, a TTR amyloidosis trial called Depleter, that's being led by Mazen Hanna in our amyloid group, the head of our amyloid group. And so this is combining note text from a progress note, which is read by the LLM, an imaging report read by the LLM, ICD code using traditional structured data, and then the prescription record, which is both LLM and structured data. All in combination to raise the confidence that this patient has a confirmed diagnosis of TTR. So I think this is an example of a good use of AI automated technology. There are some cases where it's not needed, but this is where I think the additional insight is helpful. And we've used this technology to screen around 1,500 patients with an amyloidosis code, found 30 matches for the trial, and then enrolled 7 patients out of that 30 and then stopped because we were oversubscribed. But I think clinical trials is just the beginning of the use cases for this kind of technology. Implementation is a huge aspect of how we can do this, quality reporting, operational use cases. And just to bring it back to heart failure, bread and butter heart failure, our ability to identify symptomatic heart failure, for example, is not something we can get out of structured data, but we could potentially get through AI review. And I think in closing, my takeaways are that there's great opportunities in having a curated EHR-based registry for tracking system improvement. EHR-based interventions, clinician-directed alerts are pretty limited in their benefit, but activating teams is a much better approach if you can get the resources. There's more data to come around EHR integrated remote patient monitoring that in an acute heart failure model where you're trying to scale something like STRONG, I think the first starting point is standardized identification and then automation, follow-up, and triage of risk. And then, lastly, that AI automated chart review could be the next frontier, but I think we need a lot more evidence to prove and understand the specific places it's going to be beneficial. So thank you for your time. And that's all I had.
Thank you. Moving on to the next talk is I would like to introduce Maureen Schwab, who is the Executive Director, Associate Chief Nursing Officer for Advanced Practice Nursing and Nursing Quality. She's one of our advanced practice providers at the Cleveland Clinic, and we'll be discussing harnessing the heart team for GDMT equity.
Okay, thank you. Thanks, Dr. Kaka, for that introduction, and thanks, Dr. Vest, for the invitation today. Very excited to be here. And 3 objectives. The first being to provide an overview of guideline-directed medical therapy for heart failure with reduced ejection fraction, discuss the STRONG heart failure trial in more detail than I've heard from my colleagues here a bit earlier, and then define members of the heart failure team, discuss the importance of these various members, and the collective impact on patient care. We heard Trey talk about some of the advantages in regards to EHR and how we can leverage our EHR, but that the EHR alone is probably minimally impactful at the moment. The impactful piece is the triggering of the team, but you need the team, and how do you get there? Real quick on guideline-directed medical therapy, I do have a couple slides that I will run through quickly. I think one might, postulate maybe we didn't talk enough about what we had in our slides today, but I think what is better is that it's that important. And it's that important that it shows up on nearly every heart failure provider slide, right? So this is one of the tables that you saw portions of from Dr. Estep already. What I really wanted to highlight here again is the level of evidence and the class of recommendation for these medications as it relates to heart failure with reduced ejection fraction. I split it up a little bit and have the ARNIs, the ACEs, and the ARBs all together, in those top 3, thinking of those really as a group of agents. We know that over time, the ARNIs have risen to the top, right? And they have shown that they are more effective than the other 2, but there are some cases where we can't use that. And then in fact, an ACE or an ARB, if tolerated, is more than appropriate. Beta blockers, MRAs, and our newest SGLT2 inhibitors. This table here comes from the 2024 ACC Expert Consensus Decision Pathway for the Treatment of Heart Failure that was put out by ACC in 2024. I want to highlight here what they wanted to do was put out the 10 most pivotal issues regarding heart failure with reduced ejection fraction at the moment. And you'll see on the far left-hand side of the screen here, numbers 1 and 2 deal with how do we implement guideline-directed medical therapy. It is that important. How do we get good and standardized at initiation and switching of those medications? And what does titration look like? Here is just a portion of kind of a reference table in regards to those 4 medications. We know there are other medications in guideline-directed medical therapy, but I'm going to stick to these 4 pillars today. So many of our other medications really are related to very specific patient populations or may be initiated after these are titrated up to their maximal doses. But what I want to highlight here is the starting doses versus the target doses, and really a lack of evidence overall or strong evidence on exactly how we do this on a day-to-day basis. And so over time, we've really just learned from one another, right? As a nurse practitioner in the heart failure clinic, I have the luxury of really, being able to pick every single person's mind over time. And it's been 16 years that I've gotten to go through a slew of physician partners and nurse partners, other advanced practice providers, and learn everybody's pearls and maybe their own unique personalities as it goes to when do we up titrate certain things? Are some of these drugs more important than others? Are they more important in certain patient populations? So many questions to answer, I think, which is why the ACC really put this on their list in 2024. We heard Dr. Estep also talk earlier about dose matters, right? We start at these lower doses We want to make sure the patients can tolerate them. This has to be done safely, but we know that higher doses are more effective. And so how do we get there? And the question of how quickly can we get there? Which brings me to the strong heart failure trial. You heard Dr. Martin talk about the trial pretty succinctly earlier, as did Dr. Estep, but it's a multinational open label randomized trial, the first of its kind as it relates to intensified increase of guideline-directed medical therapy over time. 14 countries, just over 1,000 participants. And again, it was randomized 1-to-1. The treatment arm was high-intensity care with the aim to get these guideline-directed medical therapies up to target in 2 weeks. 2 weeks. It takes me that long to get the laundry done at home, right? I mean, but so quick compared to how we do it, today, I think in the majority of our locations. Primary endpoint for this was really 180-day heart failure readmissions or all-cause mortality. When they set out for the trial, they set out to enroll 1,800 participants. The trial ended early. I took this quote directly from the manuscript because I thought it was very impactful. Due to a larger than expected difference in the risk of the primary endpoint between the groups based on the 1,069 total patients, when randomly assigned, the team believed withholding the intensive treatment strategy from both the current and future study participants to be unethical. Unethical, right? It was so powerful, and they came out with so many wonderful things. They said, we cannot withhold this from any other patients. We need to do this for everybody. I haven't heard about this since Paradigm, right? And Paradigm was the first time I heard about the FDA letting, this one wasn't FDA, but stopping something early because it was absolutely so impactful. Made me pause and think about my own practice. Well, geez, what am I doing, right? If I see a patient every 2 weeks to up titrate their medications, is that the way to do it? Am I doing it right, And questioning myself. Here's what they saw in regards to the doses of medications itself in the treatment arm versus the usual care arm. And you'll see in the high intensity group, there is statistical significance in regards to the percentage of those patients enrolled. So about 500 in each arm, 500 in the treatment arm, 500 in the usual care, and significantly higher numbers of patients that got to target dose of these medications compared to the usual care group. And this was done in heart failure clinics. Other outcomes, they did reach a primary endpoint with significance. You can see here the high intensity group outperformed the usual care group in regards to all-cause death or heart failure readmission at that 180-day mark. There was an increase in the quality of life for those patients who had the high intensity treatment arm, and a significant reduction, in the heart failure readmissions by day 180. There were less readmissions in the intensified group than the usual care group. As with everything, there were some considerations, and it started to make me feel a little bit better as I reviewed these about my own practice, right? What we saw, low use of ARNIs. At the time the study was done, the ARNIs were recommended. Again, this was done in many European, African countries as well, actually, where these were not widely available or widely used. So we don't see as high of a proportion of ARNIs compared to the ACEs and ARBs as we would like to, as we know we should now that we have more evidence related to those medications. SGLT2 inhibitors were not included at all. They just weren't part of the recommendations in those areas of the world at the time and were not included. They did collect some data near the end as those became on the rise, but we did not talk about those completely in the manuscript, and they were not part of the complete evaluation. It was open label, right? So people knew what was going on, so you always worry about a little bit of bias. But really, can this be generalized? This was done in a heart failure clinic. We heard Trey talk about before that, we don't have enough. We don't have enough heart failure cardiologists. How are we going to get the 55.5 million people that Dr. Sheesh told us about this level of care at this intensity? I can hardly add a patient on to my clinic in 3 months from now versus trying to get to this, right? So how would we do it? How could we operationalize it for everybody? And how could we sustain it? And this is, kind of where the equity comes in. We talk a little bit about the, differences in regards to racial outcomes in heart failure overall when Dr. Sheesh opened. But this really today, I just want to stress, is about equity overall, getting this for all of the patients that deserve it. How do we get everybody on guideline-directed medical therapy? And I'd argue with our teams. No one's going to do this alone. We need to do this as a group in order to provide the access that is needed and to provide the expertise, right? The guideline-directed medical therapy is super important. We know it works. We see it works. Also important, teaching your patients about diet, teaching them about exercise. How do they manage their own disease process at home? Those things all come together, right? And we have so many members of our team that are highly skilled in some of those areas. This is just a picture of our registration today. I took this from one of the folks that helps us organize this all together. You'll see we have 27% of non-trainee physicians. We've got 10% residents and fellows, 27% advanced practice providers, nurses, pharmacists, other. You could only pick one category too, by the way. You were secluded to what you're allowed. The other pieces of the pie up there that were too small to put the labels on, you'll see are listed over here on the left-hand side of social work, scientists, therapists, and our corporate sponsors. Go back for a second. I do just want to talk a little bit about the people who I think are missing. And you'll see this in some of the literature as you go through, but also dietitians, exercise physiologists, and even some of our therapy partners, physical therapy or occupational therapy. We know movement and activity are important and are very important. So when we think about the roles for each of these people in the ideal, kind of heart failure clinic or setting, right? Our heart failure physicians really leading the charge and setting the plan of care, right? Setting the plan of care, and then probably being taken over for a good majority of their subsequent visits by an advanced practice provider. That person can also prescribe, they can diagnose, they can recognize change, and lean into their physician colleagues when they need to. I just the other day was bothering Sean about a patient that I felt like I had maxed myself out on and I needed some help, right? And so that's why it's so important to have everybody together and working together as a team. Clinical pharmacists also in many of our states able to do medication adjustments and initiation as well. Caution though, these advanced practice providers as well as our pharmacy colleagues, the rules in each state are a little bit different in regards to what you can do. And so just be aware if you reside somewhere else than in Ohio to take a deep look at those and make sure that everybody in your clinic is working under the scope of their license. And we also want people working to the fullest scope of their license most of the time. We can't do it all the time. And I'd argue that if we did it all the time, our care would be too fragmented. And we don't want that either, right? There's a delicate balance. But we know that people are happier if they're working more closely to their top of their license most of the time. And they're more engaged in the care. Also, over half of you are Cleveland Clinic employees. So I'm going to plug your caregiver survey in regards to engagement to be completed by the 25th. In addition to the guideline-directed medical therapy, 10 pivotal issues include these things in these two columns. I will not go over these in detail because of our time today, but you can clearly see how members of our team all have expertise that can really help us get to where we need to be. One example of a study done out of Mass General in regards to optimizing different team members to help patients get to their goals was this one right here that you see in front of you. I don't know where my, but you'll see over a 16-week period, there were 2 in-person visits by an NPPA or a PharmD, and then televisits in between by those providers to help make sure that the patient's medications were titrated. Very successful. At the end of the study, we saw that an increase from 21% to 88% of patients who were in that guideline-directed medical therapy treatment arm were on all 4 medications by the time they got to the end of that 16 weeks. Hugely beneficial. And you'll also see some of the other components, right? Not just about increasing the drugs, we know they're good, but then what are the effects? And you'll see those on the right-hand side. Decrease in congestion, decrease in NT-proBNP, and positive changes in regards to the echocardiographic findings. Key points today that I would love for you to take away. One is our patients benefit from guideline-directed medical therapy, hands down. Accelerated initiation and titration to target can be done safely and effectively in a structured model. My personal take, 2 weeks with current recommendations makes me nervous. I might get there someday, but it makes me nervous. The 16-week study, very comfortable. Probably somewhere in between. There's a sweet spot. And leverage your team and their individual expertise to optimize not only their medical treatment, but also the care of the patient overall. We all have something to bring to the table. And I also implore you to make sure that you share your talents with all of those people around you. That'll be it. Thank you.
I'm going to start us with a question, Dr. Hish, about atrial fibrillation. So we always traditionally think of heart failure risk factors, hypertension, myocardial infarction, or diabetes. And we treat atrial fibrillation as a annoying comorbidity. But what do you say to our EP colleagues about managing atrial fibrillation beyond just preventing stroke and improving symptoms?
I don't know if talk without actually, but it brings up another actually important thing, which was what Jerry showed, that beta blockers, the dose effect. So it's about rate control. It really is about rate control. And in fact, it also brings up a separate issue, maybe deviating a little bit from your question, but actually with regards to women who are more likely to have AFib causing the cardiomyopathy, they also are more likely to have inappropriate ICD shocks. And there are sex differences in the risk of actually even having sudden death, so that women are more likely if they have an ischemic cardiomyopathy, but that's a very rare event. So that the majority of those patients have a tachy-induced, hypertension-induced. And so it is a lower likelihood of needing the ICD for sudden death, and there are inappropriate shocks. I would say to our EP colleagues that rate control is probably the most important thing we do. And that probably is why the beta blockers are so effective. And I appreciate the question.
Any question from the audience? There is a question online here about the ARNI and the SGL2 in the face of the high cost for the average patients, especially with the changes that are happening in healthcare, insurance, so on.
I was going to say we're very spoiled. We have a Cleveland Clinic home delivery, and they vet from a pre-approval and cost reduction strategy. Trey, I think you're best positioned, maybe highlight efforts.
Yeah, sure. I think, when I highlighted that data around heart failure specialist clinic, what I should have said is that's not alone, right? We have a team. It's really a team effort, including our nurses are helping with prior authorization, patient access forms. They're very well honed in that operation. We have dedicated pharmacists who are a part of home delivery, which is again, they know exactly what payment assistance programs are available to patients, either through the sponsor or through foundations. And those can often take the copays from $900 for 90 days down to $0, depending on the patient's financial status and what's available as far as payment assistance. And I think on the inpatient side, that's where you see it a lot too, where there's a hesitancy to avoid the sticker shock on discharge of that large copay unless there's transparency prior to discharge. And that's where we've done a lot with, our pharmacist consultation, or pharmacy techs being involved as well. And so I think price transparency on the inpatient side, cost reduction efforts that are part of a well-honed process are really the only way to help with that. And then I think, just to piggyback on what Eileen was saying about AFib, I think you'll hear some more later today about the role of AFib ablation in heart failure too. And I think a lot of us are really moving towards earlier ablation in terms of reducing overall heart failure morbidity over time and risk of progression.
I also bring up a small thing, but the strong. You brought up the fact, actually, that there was such a significant difference, and the countries could not afford those fancy drugs. So I do want to remind you that maybe 3 pillars are even important, right? And so it is important to recognize that the simple drugs we had at the beginning are not so horrible if you can't afford. I do think that if we can use the strategy, if you have the bandwidth to basically fill out the forms and get medication, that's great. But don't forget that actually that the drugs that are now less costly are still very effective.
Thank you. We have another question online about how do we approach SGLT2 inhibitors, Entresto, ARBs, the MRAs in patients who are on hemodialysis or have advanced CKD? What are the panel's thoughts?
These are good questions. Wow. I would say the SGLT2 inhibitors, the guidelines is not supported, right? So that's not really, so I think we'll just stick with what you're supposed to do. The MRAs actually used to have cutoffs, and they still sort of do, as a GFR cutoff. That is a very important thing to remember, because actually what may have been forgotten over time was that there were 2 articles in a New England Journal published simultaneously on purpose, one from the US and one from Canada, showing a very high mortality rate associated with the publication of rails with our spironolactone studies. So actually what really happened was that we were all so familiar with spironolactone, using it for our cirrhotic patients at 100 milligrams, and nobody was paying attention to actually renal function. When this came out, they all just started to use it, and there was a high mortality. So those 2 are guideline associated as absolute no's. With regards to ARNI, I think that gets a little tough. And you have to remember that a lot of our dialysis patients also are hypotensive. You have 2 groups, a very hypertensive group and a very hypotensive. And I'm going to let Jerry take over.
Yeah, so it's evolving in terms of published safety and efficacy, but I think those on renal replacement therapy, you can use ARNI or ACE or ARB. You want to be cognizant of the blood pressure reduction during renal replacement therapy, so you certainly start off low. Beta blockers, talking about a HFrEF patient population, is a go. If they're having hypotension, beta selective, metoprolol succinate in particular, I often separate it, have them take it at night, do the ARNI morning and evening. And if it's really challenging with blood pressure, I hate Midodrine, by the way. When I see Midodrine come up, right, intermittent, you can have them hold it maybe the morning of or the evening before and have a tailored strategy to individual patient. The SGLT2s, a body of work actually showing some safety of it, even in the presence of dialysis. But right now, the nephrology literature would suggest continued use until the time of dialysis, even for those stage 4 and worsening. And so there's some benefit and data to suggest that. So I would say you can use it up until the time of dialysis. I think we're going to have more data to guide us that it's probably okay to use even on dialysis. The MRAs are the ones I do stay away from. Remember, rails creatinine more than 2.5, the hyperkalemia. But if they're getting aggressive renal replacement therapy, one can challenge that. But we typically don't put them on an MRA. So ARNI, yes. Beta blocker, yes. SGL2 up until the time of dialysis. And no on the MRA. That's the practice I've been using, leveraging what we know. And that, I think, we'll know more.
Any other questions from the audience?
So we have some time. Right? We want this interactive, and all right, we'll take a question. before we get excited and activated.
And yeah, my question has to do with atrial remodeling. We talk about heart failure, low EF, normal EF, but the atrium is exposed to left ventricular and diastolic pressures. And we are very familiar with diastolic function, left atrial strain, et cetera, et cetera. But there is the issue of atrial myopathy is it's a nightmare, really, because that is what leads to this persistent atrial fibrillation, and atrial fibrillation is not well tolerated by the ventricles, whether it's a normal EF or a low EF. That's my practice. I'm a practicing cardiologist. I do a lot of ECMO nuclear, and that is a real problem. And it is true, anticoagulation is a must, but rate control is important, even more so. Rhythm, trying to.
Yeah, so great comments and question or two thrown in there. So listen, there's castle heart failure, right? Rhythm control with HFrEF is the way to go. It trumps antiarrhythmic or stent medical therapy. Left atrial dysfunction has its complexities. We know that remodeling and fibrosis, and you can have relatively normalish LVDP and have high arterial pressures, and have heart failure syndrome in the context of overtly remodeled fibrotic left atrium, influenced by many things like ablation. It's hard to tease that out. Think about what we just want in terms of an NT-proBNP, echo. I'd be happy with some strain on the LV, let alone LA functional assessments. So it's at another level in terms of it becoming prime time. Right now, I would say it is not. And so I do agree there is a subset of patients that have left atrial dysfunction as a predominant driver for their heart failure syndrome, but I still think it is a subset. I think you're obligated to treat the LV dysfunction, leverage DTMT for AFib, leverage a rhythm control strategy. There's ongoing trials with ablation and HFpEF, which are I think will be positive, but certainly for the HFrEF, I think the jury's out. I think you'll hear about that in the EP section. So it's a great comment, it's a great call out, but I think the takeaway is still leverage and optimize the meds you have and the management best practice strategies, and then reassess before you start thinking, okay, it is the driver here is LA remodeling and fibrosis. So I think you're obligated to do everything first and then say, okay, and then we don't have data on what to do in that scenario. That can be very challenging, particularly for the amyloid patients, which is a separate issue. Trey, your thoughts?
Yeah, Jerry, I was just going to piggyback on that and say that, there's a lot of interest in the device world around left atrial hypertension, in particular as something to treat, either through a shunt device or as Rishi Puri from our intervention group has recently published the possibility of doing biatrial sensing, where you'd look at the left atrial pressure and the right atrial pressure as a way to better optimize filling pressures, because there is a limitation in terms of mean PA and PAD in terms of what's going on with the intracardiac pressures. So I think that is a treatment target for the future and a monitoring target, but remains to be unproven as yet.
So Trey, just while we're thinking about this session of population health, implementation science, team efforts. So how do we get more patients with stage C on the drugs? I mean, we're using electronic record. You put a call out, there's not enough heart failure specialists. So what are the top next best steps? Is it more advanced practice providers, right? Is it more pharmacists? How do we get there?
Well, I think it's a very complicated question, but I think that it has to be, I think a broader group of providers have to be engaged, to be honest, because I think of limitations in access to cardiology and also what the mission of what an advanced heart failure center is about. I think what you saw from what Maureen pointed out with regards to the MGB group and having a dedicated optimization pathway, we also can't have the traditional, patient ownership. Oh, it's my patient, don't touch them. We have to be willing to seed the ground as a community around that. Patient ownership isn't the matter. The outcome is what matters. And so if there's an optimization clinic available or a dedicated workforce that's willing to work with your patient, we can't have traditional views, I think, on patient ownership. I think broadening the workforce to primary care PharmDs, particularly around agents that we know are tolerable, like the SGLT2 inhibitors or finerenone, that have multiple indications across kidney disease, metabolic disease, cardiovascular. Engaging more people will kind of lift all boats, I think. So I think that would be, I think, the medium answer to a very complicated question.
I'd like to add as well, I think, definitely more advanced practice providers could be helpful in many settings. But I think what our advanced practice providers need, especially those who have just come out of training, is additional training on the job, right? Nobody, whether you're a PA or a nurse practitioner or clinical nurse specialist, the programs are so different, right? We don't go through a fellowship like our physician colleagues go through fellowships. And so it really takes investment, and usually by a heart failure cardiologist or an advanced practice provider who's been doing this for a number of years. I'm going to use Sharon, that, really taking somebody under your wing. And back to that last statement I made about sharing, right? And sharing all the information that we have to bring everybody up, really for the benefit of our patients at the end of the day.
I was going to say I had a sci-fi moment. So all these are the right answer. So the other answer is AI just replaces all of us. And AI says what's your creatinine, what's your basic, it knows all the risk factors, and it says, you really should be up titrating based on your blood pressure, based on your kidney function. And that may be our future wave.
Yeah, I think AI will play a part, but that clinical pathway and decision, I think the advanced practice provider and pharmacists are going to need to do this, and scaling that can have its challenges. And training, Trey, you guys have been instrumental in the HFSA certificate, right, to be able to enhance, but that in and of itself, right, temporary efforts with getting everyone on as quick as possible and up titrating as much as possible. I think that won't close the gap alone. Meetings like this help, right? HFSA certificates help, but I think mentoring and having a best practice assessment and modeling that one can follow is going to be needed. And I think there's major opportunity.
Yeah, I also think the training goes far beyond the medicine and the physical exam and those sort of things, and the modeling, right? The modeling in regards to communication and how our teams communicate with one another, how we respect one another for the things that we bring to the table are hugely important. I have been lucky enough to be here and have gotten that throughout my entire career, which makes this great. But I see it in other areas of our organization and areas outside in regards to my advanced practice kind of oversight role here at the clinic. And not everybody is as lucky, and not everybody models that. And I think for effective patient care, the communication is going to be key and is really nearly as important as the medicine and the therapies.
All right. Well, thank you, everyone, for a great discussion. We are going to wrap up this session for a break. Please feel free to step out, visit the exhibits, and then be back at 9:40 for session 2.